This episode of Distraction is sponsored by Omega Bright CBD, formulated by Omega Bright Wellness, creators of the #1 omega-3 supplements for the past 20 years. Omega Bright CBD, safe, third-party tested, and it works. Shop online at omegabrightwellness.com. And by Landmark College, offering comprehensive support for students with ADHD and other learning differences. Learn more at lcdistraction.org. Landmark College, the college of choice for students who learn differently. Hello, this is Dr. Ned Hallowell, and welcome to Distraction. Today we are welcoming a man I've wanted to have on this podcast for a very long time. Turns out he and I are the same age, and we're the same vintage, and we've been barking up the same tree for an awful long time. William Dodson, Bill Dodson, has been specializing in adult ADHD for most of his career, and I've been toying around with the same syndrome for most of my career. And Bill has come up with some wonderful observations. And so this is a treat for me to tap the experience and the brain and the mind of a man I've respected for a long time and have really never had the pleasure of interviewing. And welcome to Distraction, Dr. Dodson.
Good to be here. I've been looking forward to this myself.
Give us just a couple of words about your background. How did you get into this world, and how did you find yourself working with people who have ADHD, particularly the adults?
I started back when I was a resident at Louisiana State University, and there was no place where anybody could go in all of New Orleans if they had learning disabilities and ADHD. So I and another resident started a clinic there that was still running until Katrina wiped out the entire hospital.
Wow.
But I've always been drawn to ADHD. I know it's somewhat controversial nowadays to talk about it being the happy diagnosis, but it really is. There's no place else in medicine where the outcome is that the person's better than they've ever been. Usually in medicine, we're just trying to get people back to their previous level of functioning.
Yeah.
But with ADHD, people are usually much, much better than they've ever been before in their lives.
So true.
I mean, it takes a lot of work. I'm not belittling that. But the outcomes are usually wonderful outcomes.
Just out of curiosity, who introduced you to the condition?
No one. I think I heard a lecture from Randy Sallee probably 25, 30 years ago. And that's what really turned me on to really emphasize and specialize in it.
And that was at LSU?
No, it was at a continuing medical education conference. And the whole subject of ADHD was not mentioned in 4 years of my training, which I think is still at least 50% of adult psychiatry residencies just never mentioned it at all.
Yeah. So you just kind of learned about it on your own.
Yeah, I'm out here in the hinterlands.
How did you get to Colorado?
I wanted to live here. I was actually practicing in Washington, D.C., and had my first child and decided that was not a place to raise children. So I moved here to Denver. You picked Colorado because it was a great place to live.
And when did you settle there?
20 years ago.
Okay. And so you just started seeing adults with ADHD and began to realize that it was a good news diagnosis. They were doing okay, but they could do even better.
Yeah. Well, also because people with ADHD have another comorbid, coexisting condition about 70% of the time, the statistic is that about 1 in every 5 people who walks into a mental health professional's office is going to have ADHD. And what I was finding was that the diagnosis was being totally overlooked. I would see patients who had seen half a dozen other clinicians, and the missing piece was adult ADHD. And it had never occurred to anybody.
And why do you think that is?
I think, again, it's lack of training. It's just not something that people look for.
It's not on the radar.
Right. When we were going through school, it was a disorder of little boys.
Yep. And a lot of people still think of it that way.
Yes. You have to almost be hyperactive and disruptive before you'll get the diagnosis.
So for people listening who don't know what this condition is, tell them how, if you're an adult listening right now, Dr. Dodson, how would they know if they have this condition?
Well, that's one of the major problems that confronts us, is that we don't have diagnostic criteria for adults that have ever been research validated. That sort of stops at age 16. For an adult to continue to meet the diagnostic criteria that we have for children, they would have to be functioning on the level of an elementary school-age child with untreated ADHD. And if that's your cutoff, somebody's going to have to be severely impaired indeed.
So how do you diagnose it?
To me, ADHD is three things. There's a cognitive piece, an emotional piece, and a arousal piece. The cognitive piece is that if you ask a person with ADHD, look back over your entire life, if you've been able to get engaged and stay engaged, have you ever found anything you couldn't do? A person with ADHD will think for a second and say, if I can get engaged with something, I can do it. The term that is out there that's used out on the Internet is that people with ADHD are omnipotential. They quite literally can do anything if they can get engaged. People with ADHD get engaged in one of four ways. The big one is they can do it when they're interested. They can do it when they're challenged or competitive. They can do it so long as it's new, novel, or creative, but by definition, that one's time limited. And they can do it when it's urgent. That's sort of the substitution for importance. In those four ways, people with ADHD can get in the zone or get in the flow and be extremely productive, creative people. The other 90% of people that they rub elbows with, the neurotypical people, for them, being interested or challenged is totally optional. They could take it or leave it. Neurotypical people use importance and rewards as ways of getting engaged, getting access to their abilities, and getting things done. And so that's one way where you can say always and never. A person who has ADHD is able to say, I have always been able to do anything I wanted to do if I could get engaged and stay engaged through interest, challenge, novelty, and urgency, and I have never in my memory been able to make use of what everybody else makes use of, and that's importance and rewards. The emotional piece is what, for 60 years, has been called Rejection Sensitive Dysphoria. I'm not responsible for these terrible names.
Who came up with that? Who came up with that one?
I don't know. It's very, very old. It's 60 years old. But on my checklist, the question goes, for your entire life, have you always been much more sensitive than other people you know to rejection, teasing, criticism, or your own perception that you failed or fallen short? And virtually everybody that I see not only checks that, they put stars by it, they underline it. What it means is that the vast majority of people who have an ADHD nervous system are hardwired. It's part of the ADHD. That if they perceive, doesn't have to be the reality, they just perceive that they've disappointed somebody, and that because of that, that person is at risk for withdrawing their love, approval, and respect, it's excruciatingly painful. In fact, that's what the meaning of the word dysphoria is. It's Greek for unbearable or difficult to bear. Because when they did the original work, they wanted to get right up there in the name just how severe this emotional pain was. And so just about everybody with ADHD will endorse that specific experience.
I mean, no one likes to be rejected, so you're saying that it's a quantum level beyond that.
Yes, it's several orders of magnitude greater. It's devastating. If you ask people, they can't describe the quality of the emotional experience, but they do talk about its intensity. It's awful, it's terrible, it's catastrophic, it's overwhelming. It just really throws people. If they internalize it, they could look like it's an instantaneous major depression.
Uh-huh.
If they externalize it, it's a rage at the person or situation that wounded them so severely.
Uh-huh. Uh-huh.
And so very commonly, these folks get misdiagnosed as being borderline because of that interpersonal nature of the trigger that sets off this emotional experience. And then the third piece is that people with ADHD have to have some sort of hyperarousal. Either they're having 3 or 4 simultaneous thoughts, they physically have a hard time sitting still, they have to be in motion. They can't sit all the way through a movie, for instance. Or something that usually goes unrecognized, they can't fall asleep at night. That as soon as it gets dark, they get a burst of energy. And when they try to go to sleep, they physically toss, turn, fidget, kick the covers off, and their thoughts bounce from one concern and worry to another. The average length of time is more than 2 hours before they can fall asleep. And so it's a major cause of insomnia that generally goes unrecognized. In fact, people believe that the stimulant class medications are going to make this insomnia worse when actually it makes it better.
Mm-hmm. Mm-hmm.
In our group, what we do is once we fine-tune the medication as well as we can, we ask the person to lie down and take a nap after lunch to prove that they sleep great on their medication. Then they know they can take a second dose and sleep normally at night. So those are the 3 things it has to be. There's a cognitive piece where the ADHD nervous system works on the basis of interest and not importance. There's an emotional piece of an exquisite sensitivity to rejection and criticism, and a third piece of some form of hyperarousal. That, to me, is ADHD and nothing else.
And so the usual triad of distractibility, impulsivity, and restlessness, you may find that or you may not, huh?
You generally do. But what I'm looking for is most people come in, one of the first things they say as a goal is, do I have ADHD or not? The vast majority of the people I see are self-diagnosed. Usually they have because ADHD is so genetic, they have somebody in the family who got diagnosed, got started on medication, they were transformed by medication and coaching, and they start talking to their cousin. Usually they try their cousin's medication, know that it works great by the time they get in to see me.
So that leads to the logical next question. Now, if this is how you diagnose it, what are the interventions? What are the treatments? What is you say this is we're going to make your life even better. What are the ways you do that?
Well, the medications are what we've been doing for 50, 60 years. The ones in the stimulant class do one thing spectacularly well, and that is when a person's engaged with what they're doing already, it keeps them from being distracted. And that's really what the stimulants do. And so what we've done is we've missed the first step, and that is how does a person with ADHD get engaged in the first place? And they get engaged through interest, challenge, novelty, and urgency. So with our people, what we ask them to do is write their own personal owner's manual for their nervous system. Most people with ADHD were given the wrong owner's manual back in preschool. All of the helpful hints, techniques, methods, whatever you want to call them, that they were offered by people, usually people who are neurotypical, and that they see working for other neurotypical people, don't work for them at all. And so they have to figure out how do they, as a unique individual, get in the zone and become omnipotential. And so it's usually as somebody's coming out of the zone that they recognize they were in the zone. When somebody's deeply engaged with what they're doing, they're really not self-aware that they are. And so it's when they're coming out of the zone and they say, wow, I just got a whole day's work done in about an hour. We have them stop right then, write down for themselves, how do they get in the zone and become superhuman? Was it because they were interested, and more particularly, what did they find fascinating? Was it because they were challenged or competitive, and what brought out that competitive streak? And a good example of that one, for the people who are listening to this podcast, imagine somebody saying, on Ned, you can't do that. What's your first response? For most people with ADHD is, oh yeah, I'll show you. And you know from personal experience that if you do have that response of accepting that challenge, whatever that challenge was, you're going to have it mastered today because you slipped into the zone. And so it's picking up little subtle moments when you go from just day-to-day life to getting in the zone and writing those down so that then you can come back and do them on demand is something we found to be very helpful.
So you have them sort of take an inventory of what are the activities that put you into the zone, what are the moments, what are the prompts?
Ways of thinking, what are the emotions that do that. It's so much of treatment in the past has been focusing on what doesn't work. What are the executive function deficits, which never made much sense to me because, once you identified somebody couldn't do something and then demand that they do it, you only get failure with that. This is recognizing when things go spectacularly well and writing them down so that you can remember to do them the next time you have something that's very important but probably fairly boring.
Right. Do they do this one-on-one, or do you have someone else work with them?
Well, I've always found that people with ADHD work best in groups where they can feed off of each other, where they can learn from each other.
So you'll do a group talking about what are the moments where you trigger into the zone?
Right, and when things went well. And, then somebody else will say, oh, that's what happened when and they tell their story. The other thing that does is being in groups helps people overcome a lot of the guilt and shame about having ADHD, is that they're able to talk with people who really get it, who've been through it themselves, that's not going to make fun of them or tell them they're doing it the wrong way because they're not doing it in a neurotypical way.
Right.
So the group has a lot of things going for it that no other modality of treatment does. Now, you can also do it with, family and friends. You can do it with teachers. You can especially do it with coaches who are able to, pass on the things that worked for other people they've coached in the past. You can do it with practically anybody, anytime.
And what else goes into your treatment plan, if you will?
We generally refer people to coaches, and again, looking for different categories of things. There's some people who just need help with organizing daily life. There are some people who need coaching in relationships because the relationship of somebody with ADHD with a partner who's neurotypical is going to have its own problems.
Mm-hmm. Do you find any particular problems recur more than others?
Well, the biggest one is that the neurotypical person expects their partner to behave in a neurotypical way.
Right.
Intellectually, they know the person has ADHD.
Right.
And they may have even done some, reading up about what ADHD actually is. But the knee-jerk response is that their ADHD partner should be behaving in a neurotypical way.
Right. Right.
The other big one is that the ADHD partner doesn't seem to be listening to them, and that will really tick people off in a hurry.
And leads to all kinds of name-calling.
Oh, yes.
Including by psychiatrists like narcissistic and those kind of words.
Yes.
Now, I know you have particular medications in mind for rejection sensitive dysphoria. Do you want to talk about that for a minute?
Yeah. As with most everything in ADHD, it's something that we just stumbled across. And that is, there are two medications that are FDA approved for the use of treating ADHD. They're called alpha agonist medications. Clonidine and guanfacine are their names. They've been around since the mid-1980s. They were originally brought on the market as blood pressure medications, and so consequently they're not controlled substances. You can just phone in a whole year's worth at a time. As blood pressure medications, they were pretty poor. Nobody used them very much. But very quickly, practitioners figured out, just through, again, real-life experience, that they were going to be the drugs of choice for a half dozen other conditions. They're the treatment of choice for tic disorders, for Tourette syndrome. It's the anesthetic they can do LASIK surgery under, a whole bunch of different uses. And for years, they've been the medication used for the hyperactive component of ADHD. And it's in that context that we started seeing, when we started medication for hyperactivity, that in about 30% of people, the rejection sensitivity would just go away. And it's a different 30% for clonidine and guanfacine. It's not the same patient population for either medication. So if the first medication doesn't work, we stop it and we try the other one. When you end up trying both of them sequentially, not at the same time, but sequentially, you get about a 50 to 60% robust response rate.
What kind of dose?
If you take all the people who get a response, 80% of them are going to be at 3 tablets. So that's 3 milligrams of guanfacine or 0.3 of a milligram of clonidine, which still means that 20% are going to be higher or lower, but by far the most common dose is going to be 3.
Yeah. And can you tell, is there any category of predicting whether of clonidine or guanfacine?
Nothing predicts response to either medication or predicts that somebody is not going to respond. It's just something you got to try and see.
So it's like methylphenidate or amphetamine. You can't tell. You just got to try.
You just got to. With all the medications in ADHD, there's no predicting. You just got to try them, and it doesn't run in families either.
How long does a trial of guanfacine last?
It takes about 2 weeks. With the stimulants, when we give a stimulant, we're going to see everything that the stimulant's going to do in an hour.
It's the beauty of stimulants.
All of its benefits, all of its side effects in 1 hour. With the alpha agonist, it takes about 5 days for the benefits to develop. So we change the dose every 5th day. So with guanfacine, we do 1 milligram for 5 days, then 2 milligrams for 5 days, then 3 milligrams for 5 days. So that takes about 2 weeks to do.
Okay. And the clonidine, you start with 0.1?
Start with clonidine, it's 0.1, 2.1s, 3.1s. It only comes in a 0.1 size. Right.
And then again, do you sometimes get a response at 0.1?
Yes, you do. That's why you take it up. It's you can get a very good response just at 1 tablet.
And a response means if someone walks up to them and says, "You're ugly," they don't go into a big depression.
Right. They will say, "Well, that person's unpleasant," and walk away.
And what a difference!
The other thing that you see is that the number of simultaneous thoughts that a person has goes from 3 or 4 down to the 1 that they want.
Wow.
A lot of people, even when they're on a stimulant medication, will still have 2, 3, 4 simultaneous thoughts going on. and that in and of itself is distracting.
Yeah. Now you can of course combine the stimulant with the alpha agonist, right?
In fact, that's how they're usually done. They're combined so frequently that the FDA has actually tested them and approved them for use at the same time.
Yeah. Well, this is a wonderful thing, and you've pretty much pioneered this, correct?
Yeah, I'm the first person that started writing about it. And again, it's just one of those things that, as you say, we're naturalists.
Yeah.
If you see the same thing happening over and over again, you know it's important. You may not know why, but you know it's important.
Right. Yeah, no, exactly. And it's a great contribution, but so is your sort of your way of categorizing all this. I know you have a book that you're on the brink of coming out with. Is that correct?
Yeah. It's been on the brink for a long time now.
Well, but you're this time you're going to. Do you think 2019 will be the year?
Well, I'm shooting for Christmas time.
Excellent. Well, please allow me the honor of writing a blurb for it. Do you have a tentative title?
Well, it's either going to be something formal like The Practice of ADHD Medicine, or something informal like What You Wished Your Physician Knew About ADHD.
Well, maybe one could be the title and the other could be the subtitle. But,
yeah.
That's often a good way to combine those two. And if someone wants to find you, is there a website they can go to?
Yes. It's DodsonADHDCenter.com.
And that's DODSON, right?
Yes.
DOD is in dog, SON, ADHDcenter.com.
Right.
And if they want to reach you, they just go to that website?
Yes.
And you will respond to them, or do you have someone else respond to them? How does that work?
I try and do it myself.
I know you're very approachable, and you also write frequently for Additude Magazine, correct?
Yes.
And that's a wonderful magazine. They do a great job. If they want to go to Additude, again, just go to, what's their website? Just Additude?
It's Additude, ADDITUDE, mag.com. It's AdditudeMag.com. One of the nice things is that they've been in publishing for 20 years, but they have everything they've ever published in a searchable format online. So if you want an article that they, printed 10 years ago on ADHD and sleep, you can pull it up from that website. It's probably the largest ADHD website in the world. They get more than 1 million discrete hits a month. So it's very popular.
Wow. They've done a great job. Sarah Kaufman and Wayne Kalin.
Yeah, excellent.
They really, and you're one of their mainstays.
As are you.
Well, thank you. And this is a real pleasure. And just, again, Dodson, DODSON, ADHDcenter.com. And if they want to track down articles that you've written in Additude, like on Rejection Sensitive Dysphoria or on any, you write the most practical articles. Truly, listeners, if you want practical, Bill Dodson is practical. He's not, in the clouds. He will tell you how to solve problems. And he also shares with me a very positive approach to all of this. He'll tell you how to make things better for yourself and not get mired in the misery of it all. And he and I have both seen a lot. We're both getting a little bit older, and we've seen a lot. But fortunately, what we've seen is how great life can be with this condition if you learn how to manage it.
Yeah.
Right. Would you agree with that, Bill?
Yeah. The word I use is embrace it.
Yes.
That if you embrace it and you start learning about it and you see what works, it's a good life.
Yep. It hurts you if you run away from it, but that's when it does its damage. And that's when you get addiction and the prison population and all of that. It's when people, and a lot of men, unfortunately, don't want to. How do you deal with them, Bill? How do you deal with the wife who says, my husband won't come to see you because he thinks it's a bunch of crap?
usually the last thing that somebody has to overcome is a combination of shame and the rejection sensitivity. They don't want to be blamed. They don't want to be the one that's at fault, that's got the defect, because it hurts so much. And usually if I can get the spouse to give them just something short in a one page on rejection sensitivity and the fact that it's got a treatment, that usually can overcome that hopelessness and shame.
Well, gosh, I could talk to you for a lot longer, but I can't thank you enough for coming on. I look forward to your book coming out and congratulate you on the wonderful, wonderful career and many more years to come. Thank you so much, Dr. William Dodson and DodsonADHDCenter.com. Thanks a million.
Pleasure to be here. Good to talk to you, Ned.
Take care.
Bye-bye.
Well, that was Dr. William Dodson, one of the great men in the field. He's truly in the trenches, been doing it for as long as I've been doing it. And, he's seen it all and then some. And he's taken what he's seen and turned it into real pearls. He's a naturalist. You can find a lot of his work in Additude Magazine, again, ADDITUDE mag.com, and he'll have a book coming out hopefully around Christmas. Well, this is Dr. Ned Hallowell. I hope you've had a wonderful summer and looking forward to a terrific fall, and I'll look forward to talking to you again soon. If you have a question for me or a show idea for us, email it to connect@distractionpodcast.com. Or better yet, call us and leave a voicemail. Call 844-55-CONNECT and leave us a message. We really look forward to hearing from you. We need to hear from you. We look forward to hearing from you. We want to hear from you. So 844-55-CONNECT or email at connect@distractionpodcast.com. Distraction is produced by Collisions, the podcast division of CRN International. Collisions, podcasts for curious people. Our sound engineers and editors are the wonderfully talented Pat Keogh and Chris Latham, and our producer is the multi-talented and unbelievably brilliant Sarah Guertin. This is Dr. Ned Hallowell for Distraction. The episode of Distraction you just heard was sponsored by Omega Bright CBD, formulated by Omega Bright Wellness, creators of the #1 omega-3 supplements for the past 20 years. Omega Bright CBD, safe, third-party tested, and it works. Shop online at omegabrightwellness.com.